Good afternoon and welcome. It's a pleasure to have you with us, either here in person or online. My name is Dr. Andy Schumann. I am the Chief of the Clinical Ethics Service at the Center for Bioethics and Social Sciences in Medicine here at University of Michigan. And it is our distinct honor and pleasure to welcome you to our Bioethics Grand Rounds event. Today we have a special treat. A dear friend of mine and a national expert is here to join us in conjunction hosting with the Department of Surgery. Dr. Binkley is currently the Director of AI Ethics and Quality at Hackensack Meridian Health in New Jersey and an Associate Professor of Surgery at Hackensack Meridian School of Medicine. He serves as a chair of the AI Task Force at that institution and a member of their AI governance board and other leadership roles within the organization. For Dr. Binkley, this is actually his second career. His day job prior to this was as a hepatobiliary surgical oncologist, and he did his training initially at Georgetown, followed by the University of Michigan, where he was a surgical resident here in the late 90s and early 2000s, and I had the privilege of learning from him as his junior trainee at that time as well. Since then, he moved on to San Francisco, where he worked for the Kaiser system for a long time and ran a cancer center, was president of a medical board, and was a full-time practicing hepatobiliary surgeon for somewhere in the 10 to 15-year range, 15-ish years, I believe. Thereafter, he transitioned his career to focus specifically on ethics with a focus on AI, and is now landed in New Jersey, where he is using his own clinical experience as well as his background in bioethics and AI to move this field forward. On a personal note, Dr. Binkley has been a forward-thinking person who's been telling me that we need to think about AI for the last, 10 or 15 years, and I did not necessarily pay attention until much more recently than I'd like to admit. With that said, it is an honor to have you, and thank you for joining us.
Great. Thank you very much, Dr. Schumann. I appreciate it. And Professor Spector-Baghdadi, thank you also for hosting me. And Dr. Dimick, I think he's gone back. Thank you all for coming. I certainly appreciate it. My husband has chided me all week that I'm going from 8 to 0 in terms of ambient highs. I was listening to NPR this morning, and it was 8 degrees in Central Park at 6 a.m. So it's good to be back here. Despite the cold, it's very, very good to be back here. And I appreciate very much Dr. Schumann's introduction. It gives you, I think, a flavor for what brings me here today and sort of how I think about artificial intelligence. So I was never, and I still am not, the tech guy. I just recently got an Apple Watch. I was never the person with the latest iteration of a computer. I never learned to code. I never wanted to learn to code. I was much more likely to be reading Ovid or Virgil than thinking about computer systems and neural networks. But somehow, this all came together in a way that makes perfect sense for me. And it really started from a very clinically based question. As a pancreas surgeon, doing a lot of pancreas surgery on patients with pancreatic cancer, and as a young surgeon, I started to notice after a couple of years that my patients were dying. And it was a bit jarring to open the medical record and found that somebody that you had operated on 2 years ago with the expectation, with the hope that they would live 5 or more years, had died. But those were the data. I knew that I had to operate on 100 patients for 20 of them to live for 5 years or more. And I had no better way of either informing them clinically or, I think more importantly, ethically, than helping them make that decision. I would have to embarrassingly say to them, you have an 80% chance of dying within 5 years, but if you're going to be in the running to be alive in 5 years, you've got to go through surgery, you've got to go through radiation, you've got to go through chemotherapy. Thinking about pain and suffering and survival as a commodity or economizing it and thinking about investment versus benefit or versus return on investment, if I were running a hedge fund, I would be in prison for losing the investment of 80% of those who invested in me and then charging them for it. So we, as pancreas surgeons, had looked at all kinds of things that may be predictive of outcomes. We had looked at circulating tumor cells. If I'm not mistaken, one of the the person for whom this lobby outside is named after, I think he did the beta carotene study, if I'm not mistaken. And I used lots of serum from that study that he had banked over here during my time in the lab, searching for markers that may predict outcomes for pancreas cancer. I worked with a radiation oncologist here, Dr. Lawrence, thinking about genes that might cause radiation resistance and make pancreas cancer more difficult to treat. We looked at all kinds of factors that may predict who would and who would not benefit from these treatments, and nothing panned out until I started to think about artificial intelligence. And I asked myself, maybe the story is more than just our genes. We've spent the last 30, 40, 50 years, Francis Collins at the NIH, thinking that the story, if we could just unlock our genes, then we would know. And I wonder if our health isn't more than just our genes. And I think we would all probably agree that it is, that it's this complex interplay between genetics, epigenetics, environment, all these other factors. And where is that contained? Where can we find that story, but in the electronic medical record in so many ways? And so it made a lot of sense to me. It made great sense to sort of think about artificial intelligence in that way. I'm in this really great position at Hackensack Meridian. We're a 17-hospital system right outside of New York City. The northernmost hospital is just across the George Washington Bridge. The most southern hospital is down on the Jersey Shore. And so I'm in this health system, but I get to wear the hat of the ethicist. I get to wear the hat of somebody who spent a couple of years in Silicon Valley before AI became a household word, helping some of the people who really are on the ground floor of AI think about this. I can remember being in a meeting where somebody said, "You're telling me I can't have access to all these patients' medical records. If I had access to them, I could cure cancer. You're preventing progress." And I told him he was being dramatic, right? But that's the idea. If we just have the data, and so how do we think about this rich history that we have of medical ethics? How do we apply those same principles to this emerging technology? And I think the technology has emerged, but I'm around boardroom tables almost on a daily basis in which we're wrestling with these questions. I'm also part of the Institute for Healthcare Improvement's AI Accelerator. I'm one of 3 physician leaders of that. And we run a monthly meeting, it's actually taking place right now, of major health systems throughout the world. The NHS is part of it, all of the major health systems in the United States. And we basically are a forum for asking questions. And so for the last 6 months, we've been asking and answering questions and sharing information and best practices around governance structures. And we moved on. And now the big conversation is around transparency. And so, well, they're calling it informed consent. And people are hung up on informed consent. And so that's really what this talk is about today. And this is very much what I've been thinking about. So what are the ethics? How can this get done in a health system? And then how can I deliver this message in a way that people who know nothing about, really not a lot about AI, but who know even less about ethics, would be receptive to and be able to operationalize. And so I'm wearing all those hats today. I welcome engagement. If there are questions, if there are things that you don't agree with or that you think are half-baked, please let me know. This is as much, I just gave a talk at the Hastings Center. The Hastings Center has, I think it was the day after the election, actually. I drove up to the Hastings Center. And it's this really beautiful drive. But they have this sort of emerging thoughts conference where you can go and sort of talk about the ideas that you have, and they can be somewhat half-baked. This is slightly more mature. I've sat more in boardrooms than libraries thinking about this, but I'm very interested to hear what you think about some of these ideas. So it's a little bit inflammatory to say that informed consent is illusory, right? So let's think about what that means. And I hate the word unpack, but let's unpack that a bit. Let's think about why, and I want to be very careful about the words, why informed consent for the use of artificial intelligence in healthcare is illusory. Is there another model? And I'm going to suggest to you that there may be, and we're going to call it informational agency. And why may this be a better model? Does that mean that informed consent is completely obsolete when thinking about artificial intelligence? No, but we're going to think about how to place it potentially in a bit of a hierarchy. And then can we also think about other ways? One of the things that's been most helpful for me about artificial intelligence is to say, how do we do this now? Right? How do our systems, because that's the best way for me to integrate something, is to say, we're doing it just like we do it. We just have to add on to it. And so might we think about something that we're already doing and basically introducing certain applications of artificial intelligence into that, and that's where genetic testing that comes to my mind. I'm not an expert on genetic testing or genetic ethics. I think we have someone with us who very much is, so I'm curious to hear what you think about that. So, thinking about informed consent, many people go back to thinking about Mary Schlendorf, who in 1908 came to the New York hospital with abdominal pain. She had fibroids. The doctor said, you need to have a hysterectomy. She said, I don't want to have a hysterectomy. They said, well, we'll just take you to the operating room, give you some anesthesia, and examine you carefully. And she said, okay, I can go over that. They took her to the operating room, they gave her anesthesia, and they did a hysterectomy. And she said, not only did I tell you you couldn't do this, not only didn't tell you you could, I told you you couldn't. So there are kind of two things going on there. There was deception, and then there was also lack of what we now call informed consent. Benjamin Cardozo on the Supreme Court of New York came up with this line that many of you, I'm sure, know very, very well. But this served as the basis, at least the legal construct, for the requirement that there be informed consent. And informed consent has both an informational and a volitional aspect to it. We have to inform, and then the patient has to give voluntary consent for whatever. And these are, the legal construct has to do with things like battery. But from an ethics perspective, we think about informed consent as a very specific thing. There are requirements, there's risks, benefits, and alternatives. Any clinician who does a procedure or who gets informed consent knows these things. So there's a process for it. It's ensconced. It's a term of art, I would even say. I was a part of a working group that spent every Thursday morning from 9 till 11 working on our harmonize. So our health system came together as really 17 separate hospitals, and we've sort of come together, and each one had its own policy. So we've harmonized that policy. So for 2 years, every Thursday morning, I spent 2 hours with a group of people rewriting that policy. And so informed consent is really at the top of my mind, is something that health systems have to do. Their compliance, their legal. We had lots and lots of lawyers. We had lots and lots of people, but we also had me as the ethicist thinking of, and also with an eye toward AI, how are we going to think about this? So I want to give that as the background about what informed consent is. As ethicists, we may have very nuanced ideas about it, but for the average person, it really is a process, it's a piece of paper. It's something that is oftentimes in health systems enshrined in policy, and they're also enshrined in law. So what is artificial intelligence? And for me, one of the ways in which it makes so much sense is that I spent most of my life trying to recognize patterns. And recognize patterns that are predictive of something, so the patient doesn't look good. As an intern, Dr. Mulholland, who was the chair of surgery at the time, told me that my one thing to accomplish during my internship year was to be able to identify a sick patient. And how was I going to learn to do that? I was going to know that if they became lethargic, if their heart rate went up, if they became febrile, they were getting sick. And then there are other ways of thinking about that. And then he told me at the beginning of my next year, your goal this year is to learn how to identify them before they get sick. And how are you going to do that? How are you going to identify people before they get sick? And that really is what the patterns are about. So this is kind of a graphic representation of how an artificial intelligence model would be able to take a picture of a cat, divide it up into pixels, basically look at those pixels and say, what is the assortment of these pixels that corresponds to a cat, as opposed to a dog or a cow, and then be able to put that together and predict, when I see these pixels, when I see this assortment of pixels, this is what this is. And then we apply that in healthcare. And how do we apply that kind of idea in healthcare? There are all these different ways. AI began to be used in the imaging specialties back in the 1980s. A broken hip always looks like a broken hip, always looks like a broken hip, right? So the radiologist can always identify a broken hip. Pathologists are masters at looking at how cells, the pattern of cells. I'm colorblind. I had a hard time with pathology because I can't distinguish colors. What I can distinguish, though, are patterns, shapes. And so I relied on that to be able to predict this is what this is, as opposed to the colors of the stains. So it's all about patterns. Dermatology. The dermatologists are masters of being able, that's their training, is to be able to look at a skin lesion and say, this is what it is based on this pattern. And then we started to apply this to predictive models, diagnoses, treatments. And just some examples, there's a surgical model that predicts patients who are at high risk of developing postoperative complications. UT Southwestern is using a model that when somebody has been acutely injured, it suggests that they either go immediately to the operating room or that they're resuscitated first and then to the operating room. And it makes a new prediction every hour based on clinical indices. There are all kinds of these models out there that are making these diagnostic treatment and technical. Surgeons now are getting prompts. I met with one of the surgeons today in the Department of Surgery who's going to take over one of the large organizations that leads in the area of laparoscopic and robotic surgery. And the surgical robots now have built-in functionality that will prompt you, stay out of that area, danger, danger, right? And so, and these are AI-based because they know the pattern that's associated with a bad outcome. The generative AI models, the chatbots, the ambient AI, same thing. When it sees these 3 words, when it hears the specific tone, it predicts that this would be the next word. There's a new dimension of large language models where it's large concept models. So instead of just predicting the word, it's predicting the concept, and it's going to match those in 2 dimensions. If any of you read The Atlantic had the top, I think, 4 or 5 innovations of 2024. One of them was generative AI, the other was quantum computing, and now marrying quantum computing with generative AI is going to be able to predict things in multiple dimensions. Right now, we're limited to fairly binary decisions. This will allow us to go into many more dimensions. And then the operational aspects of running a hospital or a health system, things like staffing. I was at a large meeting of health system leaders, and they've got, the University of Pittsburgh has like 12 hospitals all over that area. And they have a model that predicts this patient should go to this hospital, this patient should go to that hospital, this patient should be transferred, this is a better level of care, the outcomes for this particular clinical issue are better here, and they basically, they switch people around, they move people around. And then this is the last category that causes me the most concern, and that is the prediction of future health states. And it's not something that a lot of people are talking about, but I think it's the most ethically fraught of these. And I'll tell you a little bit about that and tell you why. So why is the use of AI, why do I consider it illusory? And so this sort of sums it up. It's neither possible nor necessary for every use of AI to have informed consent. First of all, it's just not possible. It's not feasible. You would have to get informed consent for the cell phone that your clinician is using. You would have to get informed consent for the CT scan because it's running. Your centrifuge in your lab, every use of artificial intelligence, if you're going to focus on informed consent and use of artificial intelligence, that would be the requirements. Simply not feasible. And not every application of AI really meets the need for informed consent. Do you really need to get informed consent for an AI model to centrifuge your blood to predict how long that test tube should be in the centrifuge? No. So it's both not feasible and it's unnecessary. Do we get informed consent for most of what we do in health systems? No. So this is why it's illusory. It's illusory because it's not feasible and it's not necessary. The other piece of this that I sort of want to focus on is that we need to broaden the consideration. We're focusing now on informed consent. So I've argued why informed consent may not be the best model. Now we're focusing on informed consent for the use of AI. What does that even mean, right? Where should the focus be? And I suggest to you that the use of AI is insufficient, that really what should be talking about is where the risks and the benefits are to the patient. And the risks and benefits, in my mind, rest largely in a patient's agency over how their information is used to make a prediction, and then their agency over that prediction. How is that prediction used? Who knows that prediction? Do they want to know? One of the things that we as clinicians are the absolute worst at is entertaining patients' informational preferences. Because we tend to go in and say, do you want to know if you have cancer? Right? Then not useful. We're not very good at trying. I work with a group of, I do simulated patients with our medical students. And I watch our medical students struggle with that, asking a patient, what do you want to know? Right? Well, what do you know that's important to me? So it's we can sometimes get to these very circular conversations. And so I think part of it, so I think here I'm suggesting a couple of different things. And I don't think it's just semantics. I'm suggesting that the two ends of this schematic is really where we should be concentrating. So this is how an AI model works. The center part here is the model itself. The model has been trained, it's been programmed. A data scientist can tell you how many unique pieces of information, how they were organized, all those sorts of things, how they were validated. But that's not, I think, for most patients, what's relevant. And I also don't think that's what's really ethically relevant, is how the model, it has its own ethical concerns, a set of ethical concerns, but I don't think those are the clinical concerns. I think the clinical concerns occur at the two ends. And I think really the ethical concerns here don't require informed consent, because I think we're going to have to assume at least that by the time those models are deployed, even if they are not fully functional, even if they're not completely debiased, it's not up to the clinicians that's not the clinician's role. That's not what should be going on in the informed consent conversation. Patients should not be asking whether or not the model is biased. Those issues need to be resolved before they're deployed. So what I'm really talking about is informed consent on the part of the patients. And so focusing from the use of the model and instead concentrating on the patient's data that's being used to drive the model, to make the prediction, and then being concerned about the prediction and how it's going to be integrated into clinical decision-making at this end, and also thinking about the prediction and the risk of it being known, going into their electronic medical record, and having a value-based conversation about the prediction itself. And so that's where I believe that the emphasis should be. And I think instead of thinking about informed consent, we should keep that concept as a term of art applied to very specific instances. And what we should really be concentrating on, because when people start talking about informed consent around the boardroom tables, what they're thinking about is having patients fill out a form. And I try to translate that to transparency and shared decision-making. So what am I suggesting that we shift? What's the proposed shift? From informed consent for the use of AI in healthcare to what I'm calling informational agency, the idea that patients should have agency over their information and how their information is used, and then the information that's generated about them. And that should be ensconced in transparency and shared decision-making, and that we need to sort of shift our thinking in that direction. So what does this model address? What concerns, what questions? I think it helps, or it answers the question, asks and answers, do I want my personal information to be used by this model to make this prediction? Do I want to know the prediction? Do I want to have the prediction known? And I want to make, I think there's a distinction between, yes, this prediction can be made. I can see how it may be beneficial, but I don't really want to know it, right? It may be beneficial. Right now, what I see happening, and this is a little bit of where my mind is in this area, is I see health systems, I see insurers, I see public health entities making lots of value-sensitive predictions without the patient knowing that knowing that they're going to make the prediction, and not being told what the prediction is, but that information being used. And I am very troubled by that. I am far less troubled by the pathologist who's using AI to be able to make a diagnosis that's related to my illness or to a patient's illness. So let's talk a little bit more about this. How do we actually think about this, and how might this model of informational agency be more beneficial than concentrating on the use of AI? And I'm going to suggest at least three reasons. One is that I think it makes a stronger rights claim. Second is that I think it emphasizes decision-making about information rather than about the use of AI. And the third is that I think it supports expanded agency over real-world data. So what about our rights claim? So here we have our good friends, the rights ethicists. We have Hobbes, Locke, and Rousseau, who really sort of think more in terms of rights. I am not a rights kind of guy, but I think there's something here that may be important. I think that when we think about rights, a patient has a greater rights claim over how their information is used to make a prediction, and whether or not that prediction is made known to others, then they have a claim for whether or not AI can be used in their healthcare. And I think it's a very nuanced, it's an instance-specific conversation. And I think it's also something that makes a lot more sense. I think that I do think that there's a stronger rights claim. A patient can't say, I don't want computers used in my healthcare. I don't want electricity used in my healthcare, right? There's some things that if you say, I want to be treated, we have to actually take, and I think AI is going to be one of those. So what about the other piece? What about emphasizing information rather than use? A lot of what I hear is, how are our clinicians ever going to be transparent about an AI model? They can't answer questions about how the model was trained, how it was validated, how accurate it is. They're just not qualified to do that. They're not. We should not be. We can't have data scientists running around hospitals consenting patients for the use of AI. It's just not practical. And it's misplaced. What clinicians absolutely must be able to do is to be able to talk to patients about, this is a prediction that's going to be made about you, particularly about a future health state. Here are the risks and benefits of that prediction. Is that prediction mitigatable? Can I do anything about that, right? Tell me what that benefit of that prediction is to you. What are the potential harms of that information going into your electronic medical record? Any prediction that uses Epic, any AI model that uses Epic, automatically places that prediction in Epic. It's just the way that the functionality is built. This is a whole separate talk, a whole separate conversation. I'll just give you a little bit of a teaser. That is, we're making lots of predictions that we don't know what to do with. And I'll give you an example. And I ask, when I'm teaching medical students about liver and pancreas tumors, I ask them, what is the smallest tumor that can be detected in the liver? It's about 4 millimeters. That's by a human. What's the smallest tumor that an AI model can predict? It's at the level of pixels. The clinician can't see pixels. They can't see things at that level. So the AI model calls their attention to it, and then a radiologist, best radiologist in the world, looks at it and says, I don't see anything there. But what do you do about that, right? Do you say follow up in 3 months? Do you tell the patient? Do you tell the referring person? How do you actually keep track of that? So, right? So this is becoming a huge concern, and I use radiology just because it's so concrete, and the people who are leading AI in radiology are so smart. But this is happening everywhere. There are all these predictions. There's a mortality predictor that's becoming very, very popular. And it predicts, or let's just even take an easy, less ethically fraught one, and that's clinical deterioration. There are clinical deterioration systems that are built into the electronic medical record. They will prompt a clinician, this patient is at high risk for clinical deterioration within 48 hours. Clinician goes to the bedside, patient looks fine. right? So what do you do about that? I'm working with a group on a model to be deployed to low and middle income countries that would predict wound infections before you actually see a clinical wound infection, but we don't know what to match as the clinical intervention. Do we put the patient on antibiotics when we predict them to be at high risk? I mean, this is beyond sort of our clinical scoring systems. And I want to make a really important distinction here. We're not talking about clinical scoring systems. I have all kinds of clinical scoring systems that predict the risk of wound infection. What we're talking about is an AI model that makes a prediction that's unexplainable, that we don't really know what to do with, and you can't unknow it, right? It is not sufficient to say, so when it pops up as an alert in Epic, this patient is at high risk of deteriorating, you can't not know that. You have to act on that clinically. If we've said that it's beneficial enough to tell you, right, you simply can't close the box. You have to either say, I've evaluated the patient, I disagree, click, or here's what I'm going to do in response to that. Same thing is true about those 2-pixel microcalcifications on mammography that an AI model has identified. We don't know if that's even clinically relevant. We don't know how many of those will actually progress to breast cancer. So we're at this point of unknowing, and that's an epistemic question that I think we'll probably know at some point. What we're talking about here is really what's within the clinician's purview, what a clinician we can reasonably expect them to be able to do. The other piece of this is that right now, PHI is very well defined. We have a list, we know exactly what's in, what's out. That list is increasing every day. Our mental health, people who are doing AI mental health are looking at all sorts of things that are more predictive. Accelerometers, how quickly are you moving? To what extent are you horizontal versus vertical? How quickly do your eyes blink? How many mistakes do you make when you text? All these things seem to be in many ways, much more predictive than what's in the electronic medical record. So if we concentrate now at this point that PHI is very well defined, and if we say, yes, patients should have agency over that information, as that list expands, patients can continue, I believe, to claim agency over that information. And particularly as the lines get fuzzy, right? Lines very fuzzy. I don't know how many of you can calculate your VO2 max, but mine, I get an alert when my VO2 max is too low, right? All kinds of things is being recorded about us. And it's not just for an individual's edification. So does this mean that informed consent is obsolete? No, it has its place, but I think it has its place in a tiered approach. I think there are degrees of informational agency. We have to have something to call this besides informed consent. It's not informed consent, it's informational agency. And we have to think about degrees of transparency and shared decision-making. And I think we think about disclosure, and I think we think about assent, and I think we think about informed consent as the highest level. So what are the variables to consider when we think about whether it's going to be disclosure sufficient, whether assent is sufficient, or whether we need either verbal or written informed consent? And here are the 3 axes that I think about. One is, what is the relatedness of this prediction to the patient's current condition? How related is this to the thing that I'm treating them for, or that they want to be treated for, the thing that they're requesting information about? How related is that? Second is, what is the value of the information to them? Is this something they want to know? How do they want to know it? Do they know, have they thought through all the ramifications of knowing it? And then the third is this something they want to be known widely? Because you can't control, it's very hard to control information right now. I just wrote our AI use policy for the medical school. And I didn't know to what extent, I knew that the commercially available generative AI models were not secure, but I didn't know the extent to which they're not secure. They're really, really not secure. I mean, they're really, really not secure. And so basically putting something into a generative AI model is like putting it into the internet. Like you've lost control over it. And so part of medical school generative AI policy really has to do with security of personal, not just PHI, not just things that are in patients' records, but personal information, things that they might do in surveys, things that, and the proprietary information that in class, every handout is proprietary, right? And so we have to think about that in this context. So what is the risk of harm? So I have this, what I think about is sort of a pyramid, a tiered model. So actually, I think for most applications of AI, disclosure is going to be sufficient. I think for some, assent is appropriate. For instance, ambient AI, I spent Monday, most of my day Monday talking to ambient AI vendors. We're probably going to deploy more than one vendor, and we're going to sort of compare them and see how they do. A lot of what I talk about with those vendors, I talked about two things. I talk about how much of our data they're going to use for training. And then the other thing that I talk about is, tell me how you're scripting the conversation with patients. Because it does no one any good for us to pay hundreds of millions of dollars for a bunch of ambient AI that clinicians are not going to use because they don't know how to talk to patients about, is it okay with you, right? If you don't talk to patients, so the cell phone sitting between you and the patient. If I start out by saying, Mrs. Smith, do you mind if AI listens in our conversation or just summarize what happens because it's much more accurate? I forget things. This is a better way of capturing your, and it gets me home at night. I really love my family. Chances are Mrs. Smith's going to say, fine, absolutely. If halfway through the visit, Mrs. Smith says, doctor, are you recording me? And I say, oh yeah. Mrs. Smith is going to be rightly outraged, right? And it would be, I think it would be, I think my fiduciary responsibility to her, prioritizing her, would be absolutely gone. I think that there would be a huge rupture of trust. So I think crafting that conversation is extraordinarily important. And in that case, I think assent is fine. For a few, I think informed consent is required. And I think particularly for these predictions of future health states that really nobody's thinking about, that's what worries me the most. And I will tell you, well-intentioned places are doing this, and we'll look at that in just a second. So this is what I came up with. I have been toying with this little chart for ages and ages and ages, and giving this talk finally made me put it down. I have little stick-it notes all over my house where I have these ideas, and I start writing them down, and I'm like, nah, that doesn't work. So I think this is the closest I've gotten it to work. So how do we think about these three? And I tried so hard to put three columns as relevance, value, and harm, and be able to sort of calibrate it and come up with a scoring system. It just doesn't work. I'm sure if I had enough time or if I had a data scientist, I could get it. Somehow we have to think about these three things, and it's a little bit right now soft about how we do that. In some cases, I think we have to, so this is the use case I come up with. If somebody is admitted, if I see a patient in the hospital who has an altered mental status, I must do a toxicology screen. I must do a drug screen, absolutely. If I simply go and see one of my patients and I think, it'd be nice to know if you're using drugs because using drugs are bad and I can counsel you and I may be able to save your life, and so I'm going to test you for drugs. I think that would be a huge, huge, huge violation. I think it'd be a violation of trust. I think that it would also be an invasion of their privacy. Although there is no rule on the book saying that I have to get informed consent. I can do anything. I can log on to Epic and I can do these things and I can order these things. So I'm very concerned about that second class of patients that we just decide, oh, this would be beneficial to them. And in what way? So here are some of the models that I know are not just being developed, but are being actively marketed. I was on a call the other day as the ethicist with a group of places that are using an HIV predictor model. But HIV is bad. We want to eradicate HIV, right? We don't want anybody to develop AIDS, but should we really be running a prediction routinely about, and the way this is working is that there's actually one place in which it's deployed in the emergency room. So somebody comes in and they've broken their leg and we say, oh, you're maybe at high risk for HIV, right? Do you want to go on PrEP? It's good, right? Knowing if somebody is at high risk for HIV, having a PrEP conversation, if they want to be started on PrEP, starting them on PrEP, and then keeping people from developing AIDS, these are all beneficial. But so are lots of things that we ask for patients' consent or patients' assent that we inform. I just want people to be informed that this is happening and to be able to participate. And then this goes in your medical record. So let's say that, and they're very valid. They're like 98% valid. They go into your medical record and then you say, no, I'm not at risk for HIV. So how does that look, right? 98% accurate, no. It's like the adage, if they tell you they drink 4 beers a day, they drink 8, right? This is it'll create this mistrust, and it'll also be stigmatizing to those patients. The other part of that I realized, and I'm just picking on HIV, and this is the story that I tell, is, somebody comes in and the clinician's like, oh, there's no way they're at risk for HIV. That's Father John from St. Andrews. There's no way he's at risk for HIV. He's celibate, he's a priest, right? And so they don't counsel Father John. That's ridiculous. Father John comes back in 6 months with HIV. And in his medical record, there is an alert that was ignored 6 months before. And he says, why didn't somebody stop me? Why didn't somebody tell me this was out there? Like, you mean you had an opportunity to prevent me from developing HIV and you didn't do it? So what's the ethical responsibility of that? We don't know what to do with most of these, right? We're guessing. We're taking clinical. So I am comfortable with anybody assessing for any of these things using clinical criteria. Very, very comfortable. I'm very, very uncomfortable with people assessing for these things using an AI model without letting the patient know. There's a big difference between making a clinical assessment and making a prediction, and it's not just semantics. And it's not just the technical aspects, right? A clinical assessment, you actually exercise your professional judgment. That's not what this is. People are using this as a nudge. Oh, let's use this as a nudge. Nothing this accurate is a nudge. A nudge is, have you screened this patient for HIV? That would pop up on every single patient. But to single some patients out and say this patient is predicted to be at high risk for HIV, the suicide predictor, it's actually, it's picked up a lot of momentum because it's been effective, right? But we're not looking at, and I've been in a number of these conversations, particularly the violence predictor, and they're like, no one is capturing the harms. No one's assessing for the harms that occur. Everyone's saying, oh, this reduced the risk of suicide, or this reduced the risk. But how many patients were, well, no one is surveying for those uncaptured, unknown harms. Dementia, and then the adverse events. There's a predictive model for pancreatic cancer that I know of because I'm a pancreas surgeon. There is not a thing in the world I can do for a patient who's predicted to be at high risk for pancreas cancer that's been proven, except for take their entire pancreas out. That's really all I can do to mitigate their risk. How often do you scan them? How often do you do an endoscopy? We don't know the answer to that. We have some information from hereditary pancreatic cancers, but that's a very, very different application. I think we have to be a little bit circumspect on applying those clinical models to AI. So what are the things that I think about in terms of predicting future health states? And I think about these things. It may not be related to the current illness. I hate to say this, but a lot of these models are being rolled out as operational for cost savings. If we identify patients who are going to die, we can get them into hospice. If we identify patients who are at high risk for violence, we can do these sorts of things. They're really operational. They're not necessarily geared, or we presume that they're beneficial to the patient. Patients want to know when they're going to die, right? That's a huge assumption. We're also not validating these. We're not testing these. These are accurate, but we don't know if they're beneficial. And that's an important distinction with AI, is they may be valid, but validity does not translate into benefit consistently. So can genetic testing inform us? Is there something here about genetic testing? And the reason that this comes to my mind is that everyone that I've talked to about this sort of idea, they've been, oh, this is very similar to some of the things that we do with genetic testing. We ask the question, is the test related to the illness? What is the value of the information? And sometimes the value hinges on whether or not it can be mitigated. And then could the individual be harmed if others knew the information? I think yes. And that's why we have the GINA, the Genetic Information Non-Discrimination Act. I think we probably should be thinking about something like this. I do think that this particular category of predictions, I know for a fact that large payers are running these predictions on us. I know it 100%. And I think again, I'm not a conspiracy theorist, and I'm a very, very trusting person. I'm a really, really trusting human being, but I also think they're probably guiding decisions in a way that they're keeping as hidden as possible. They're burying them in code. And So I also know that health systems are using these. The health systems, the issue that I have with health systems using these is that there's this presumed benefit. Two things. One is they've never been proven in a clinical trial, right? So accurate, beneficial. The other thing is that they're presuming that patients want to know this information. And I think that's a huge assumption. And in some cases, they're running the prediction and they're not telling the patient the prediction. I think early in the days of AI, there was this idea that there could be push or pull. Like if a clinician wanted to know something, they would push a button and they would get the prediction. These are all going to be pushed. It's just, you can't pull. You can't decide if you want an AI prediction. It's not a la carte. When you log onto the electronic medical record, it's going to pop up and you can't not know it. Really, a big part of my role is figuring out how to match an intervention to the prediction, so that the clinician's not left just with knowledge they don't know what to do about. So hopefully I've helped to think about how informed consent is very narrow, and what we need to think about is a larger concept of informational agency. How instead of concentrating on the use of AI, we need to think more broadly about information, both information in and information out, and how this particular class of predictions, I think, deserves a really high level of scrutiny. So thank you. I welcome your comments, your feedback, anything. So thank you very much. Yes.
Thank you. That's so interesting. I especially appreciated how you made sure we were all on the same page before we sort of got into the deeper ethics, because it's a very optimally diverse audience here in terms of what we focus on. So that was really helpful. So I agree with almost everything you said. Here's my question of where I keep hitting a wall myself, is with the argument of ensuring patients have decisional agency. So agency, as we know, is not objective, it's subjective, and some patients come with more than others, which we've worked with, and we're used to that. We're used to having to go more into education or whatever for certain patients because they don't have a lived background. But when the tools themselves come with more biases towards some of our patients, that's a more unique problem, right? So if we're talking to a Black patient with pancreatic cancer over the age of 65 who also has diabetes, we're going to know a lot less because of the data that's already in the system than our average white patient, right? Like 90% of these models are like literally from Harvard and Stanford. So I've heard people argue in the literature, well, just tell patients that. Just say, hey, here's the tool, and by the way, it's racist. Like, do you want to use it? And I was wondering your thoughts on like not just the agency that the patient comes with, but like the accuracy of the tool.
Yeah.
What do we do with that?
It's such a great question. And so the presumption in this talk, and I probably should have highlighted it more, is that the model is good, right? The model is valid, it works, it's not biased. I want to talk about, I just want to address bias first, and then think about the idea of a data nutrition level. And help me remember both of those, because I'm afraid I'll forget. So I think, and I think we're going to wind up with several very good data sets. And I think that we can debias data sets better than we can debias humans. I think it's going to take a lot of work to get those data sets. I think that the risk of having these really excellent, debiased, accurate, valid data sets with ideal patients is that it's going to become Shannon Valor's AI mirror. So Shannon Valor in Scotland has this new book out, and she basically says that we're never going to move because we're just going to repeat our data again, right? We're going to stop innovation. Completely off the subject. Oh, so on the subject, but different. I was reading over the holidays. I was reading this scholar of ancient languages, who basically says there's been this idea that if we could just get some of these texts, then everything would be fine. Like we would know, it's like the missing link. If we just had these texts, we would know exactly what they were doing, and then we could fill in all the blanks. And he said that this is based on kind of a flawed genetic presumption that they were basically scholars in the early 1900s were trying to apply a scientific method. Like if we could just discover this, we could fill it all in. And that language, that the embodiment of language in literature is more than just the gene expression, but it's really this interplay between science and social constructs. And I think there's something about that with AI. AI, there's this assumption that, so George Church at Harvard, the geneticist, has this idea that we should actually be putting our genome and our electronic medical records up. He also thinks that dating apps should contain your sequence genome. So take that for what it is. Anyhow, so there's this idea that AI is the perfect, it's basically gene expression. It's our genotype, right? So we have it's our phenotype. We have our genotype and our genetic code and our phenotype and our electronic medical record. But it's not quite that, right? And that's in some ways what we want to capture, but what we don't want to capture. We want to capture the diversity, the diverse interplay between genetics and environment. But in the best possible way. We don't want to capture those patients who have incomplete medical records that we don't know what happened. We don't want to capture the patients who got substandard care. We can, if we create really good data sets, I think that we can circumvent that problem. I think about some of the AI problems as sort of falling into categories. Like, is this an essential, or will we sort of figure this out? And I think this is one that we'll figure out. The data nutrition label, I think, is really interesting, and Mark Sindak has done some work with that at Duke, and the idea is that, basically, this was in some ways not born out of, but the group at Baylor have this heart failure model that predicts very well patients who would benefit from a left ventricular assist device for heart failure. It works really well on middle-aged white men, middle-aged and older white men, because that's who got referred to the heart failure center at Baylor in Houston, who had insurance and who could get in. And there's also this self-selecting bias. It was the one that the clinician said, oh yeah, you'd be good, right? It works very well. And so this whole question came up is, do we tell the rest of the world this doesn't work on you? If I had an antibiotic, let's just do the thought experiment. If I had a chemotherapy agent that only worked on middle-aged white men and did not work on anyone else, would it be ethically justified to basically say, I can't give this to you. I'm sorry, you have to succumb to your cancer. I can only give this to middle-aged white men. We would never accept that, right? I think that if we say something is beneficial, we have to have an equitable distribution of benefits and burdens, right? Before we can actually, if not, we risk being like Malibu and having our own private fire departments when our houses burn down, which I think has its own ethically fraught aspects to it. But the whole idea is that if we have something that's beneficial, we have to have equitable distributions of burdens and benefits, and we can't give the benefits to one group and not to others just because it works well on that group and not on others. We have to build those data sets. There are ways of doing that. Dr. Schumann has a paper in Nature last week that talks about 3 ways of taking small data sets and making them bigger. So I think the data scientists, they're doing all this stuff with synthetic data. You can take basically small data sets and then have an AI model actually create a larger, there are all kinds of interesting things that people can do. So I think ultimately, the biggest long-term risk of data is that we're basically just going to keep repeating ourselves. So thank you for that. Yes. Yeah. It's, again, such a wonderful question. I see my role as thinking about, so I think about harms in a number of categories. There are the predictable harms that may be largely hypothetical. And then there are things that we never even thought about. It makes me think of this cardiac surgeon that I worked with when I was a medical student, who would see the patients the night before he would do a heart operation on them, and he would go through this whole litany of everything that could possibly happen, and then he would pause and he would say, and then things I've never even thought of. And so that was just his way of kind of, so I do think I was on a panel recently and I was asked if I had a magic wand and I could prevent anything in the future relative to AI, what would I prevent? And there's going to be a lot of people hurt in ways that we can't really predict. And some of them are going to be hurt without knowing. It's so occult that, like, if a payer decides that they don't want to pay for you getting something, they can find any number of reasons to deny you when the real reason is that an AI model predicted that you're at high risk or whatever. So, so I think that, I think there are a lot of harms. I think that users of AI, this is tomorrow's talk, I'm giving surgery grand rounds on AI. I think that users of AI are at high risk of being hurt in ways that I don't think they're aware of. I think in medicine, I met with the folks from UpToDate the other day. They want to put UpToDate in our Epic, in our electronic medical record, so that it would basically be looking over a clinician's shoulder. Do you know about this? You would be typing your note and it would prompt you. So, or if you said, based on this, I'm going to recommend this antibiotic and it disagreed, it would prompt you and give you an alternative and, a nudge. If you override it, it keeps a track of you and it runs a report. And it says that these are the number of times that this person overrode, and here are the outcomes. So I think that, clinicians may have no idea that that data is being collected about them. The surgical robots, we're collecting a lot of data about surgical kinetics. We can actually, without any data about the patient, just look at the surgeon's kinetics and predict what category of risk for complication they're in. We've always said, as a surgeon, if somebody has a bad outcome, we say, oh, they were bad protoplasm. What if you're just a bad surgeon? What if you had a bad day? What if you're a little off? What if you had one too many cocktails the night before? There's no police. There's nobody that checks you in the morning before you go to the operating room. That's your conscience. You have to decide. But what if the AI model says, your kinetics are so far off that you're dangerous? And so there's some people who want to basically have the model lock up until you go get somebody else to unlock it if you're too dangerous. A related question about quality is, if the AI models outperform us, as they're almost certain to do, at what point do we say we either have to up our game, or at what point do we say we have to step aside? Now, I can tell you from a patient experience perspective, seeing lots and lots of surveys about some of the generative AI models that are doing things like informed consent. I run an AI ethics lab at the medical school. I've got about 30 medical students. I'm always trying to find them opportunities. And one opportunity I found them was this group called Open Notes at Harvard. And they basically they start out with this idea that things should be transparent. And we're kind of playing with the idea of using AI, particularly in pediatric populations, to help with the informed consent conversations. But one of the ideas that comes up there is around the transparency and how do you actually capture these things in an AI model, and how does a large language model communicate these things? And then how do we think about those risks of harm relative to a large language model also? Thank you for that. Yes.
Final question. So yesterday there was an executive order allocating $500 billion for private industry to use AI however they see fit. Thoughts on when that magnitude of money is coming with no strings attached? What is the role of academia and ethicists to either pump the brakes or at least inform folks about the parts that we may have under our belt?
So I am not a nihilist. I'm not lots of things. I cannot spend the next whatever many years being outraged. It fails. It hasn't worked. I admire the people who can voice outrage, but the current climate is such that it's misdirected. It's just, you're going to be bulldozed over. You can write the editorials, you can carry the picket signs, you can throw yourself in front of bulldozers, you can do any of those things. And you may go down in history as a martyr, but you're not going to affect very much right now. there's some value in being a martyr, but I'm not sure it's going to affect change. I think the best thing to do right now in terms of helping make sure that that money is guided is actually, and I hate to say this, but I think it's partnering with those organizations. They want what we have, we want what they have, they need what we have, we need what they have. I think that that is the only way. We're gonna have to roll up our sleeves and we're gonna have to hug Elon. I mean, we are, and we're gonna have to do it open-heartedly and lovingly. I think that's the only way this is gonna work. And not just to get Elon's money, but to give Elon, you know, there's a certain prestige. So I worked with some brain-computer interface stuff when I was in Silicon Valley. This is adjacent. So I wrote this paper about BCIs with somebody who's a tech ethicist in Silicon Valley with me. We got some attention from Neuralink. We got some attention from the Government Accountability Office. So I've spent the last 2 years, almost once a month, meeting in groups with the GAO, advising on the ethics of brain-computer interface devices. And what I've learned the most is with the other people in these groups. And a lot of these people in these groups are from Neuralink, they're from Google, they're from Meta, they're from Alphabet, they're from all the big tech firms. And they want to know what we know. They live in a world in which it's not particularly academic, it's not particularly intellectual, it's not particularly, and they have a little bit of envy for us in the way that we have a little bit of envy for them. And so I think as much as we can create those marriages and not villainize each other quite so much, I think that's how we're gonna do it. Because we bring the conscience. I think we bring the conscience. What we can't do is we can't trade the conscience out. I mean, when I took this new role at HMH and I'm sort of, I'm really advising this highest level of our organization on AI. One of the things they said to me is they said, we're gonna put you on this committee with all of our executive leadership team, but we don't want you to lose your voice, right? You still have to be the ethicist. You still have to stop us if something's not right, right? You're joining this to speak up, not to prevent you from speaking up, which I thought was a really subtle but important, made me like them even better. I mean, you know, I don't always find myself at home in those places. It's just not how I work. But when they said that to me, I thought, you get me, right? You get me, and you get why I'm here. So I hope that answers your question. I think we need a partner with them. I hadn't really thought about that, but I think I have been thinking about that because I've been thinking a little bit about what does it mean not to sell out? But also what does it mean? Again, there's an article in the New Yorker recently about I'm getting a little bit of breath, but about the Jewish feast of Sukkot and about the importance of faking it till you make it. Basically going through the motions, even if you don't feel like it, and that there's some intrinsic value in that. And a bit of a departure from the idea that we should just be honest about our feelings and we should just let our feelings out and we should just voice them, that maybe there's something to kind of using higher level control over that and saying, you know, and again, I don't know Jewish theology well enough to completely understand it. I may be doing a bad representation, but I think I'm paraphrasing the article at least, where there was this idea of even if we feel outrage, even if we feel anger, we sometimes need to set that aside for this higher value. And that has so stuck with me because I think so much of the paradigm psychologically, emotionally, socially, politically has been, you know, just get it out there and just, you know, be angry and be outraged. And what this author was suggesting is that maybe we needed to exercise some more of our, and I'm not a neurobiologist, but some more of our frontal cortex and saying that there may be some benefit to kind of faking it till you make it.
Thank you so much.
Yeah, thank you all. Thank you very, very much.